And there we go. I got a notification. We're recording this presentation today as part of the Avatar quarterly meeting. It is a huge honour for us to invite and receive 3 presentations today before the quarterly meeting. So without further ado, I'm actually going to pass over to our chair for this presentation, who's Gillian Ray-Burrell, part of the Avatar group, and she's going to introduce our speakers and give you the rules for today. So without further ado, thank you so much to our speakers and to Gillian for chairing this session.
Okay, thanks, Andrew. I hope everyone can hear me. Yes? Okay, so just a reminder that the session is being recorded. So we are so honoured and excited to have 3 amazing speakers here today. We've got Lisa Gorski, who's a distinguished clinical nurse specialist and educator. She's got over 35 years experience in American home care. She has degrees from the University of Wisconsin-Milwaukee College of Nursing. She's an accomplished author with over 70 book chapters and journal articles. And I have cited her many, many times for her role with her leadership with the Infusion Nurses Society and the standards, etc. We're super excited to have her here as our first speaker. And Lisa will be followed by Barb Nickel, who's a clinical nurse specialist in Nebraska. She leads staff development and process improvement in critical care, infusion therapy, sepsis, and new graduate transition. Barb is an expert in infusion-related topics. She co-authored the 2021 Infusion Nurse Standards of Practice, and she's the chair of the 2024 9th edition committee, coming out very, very soon. We're all excited about that. And finally, we've got Lynn Hadaway, who is, the name is obviously well known to everybody in the vascular access field. Lynn is an infusion nurse, nursing and education expert with over 50 years of experience. She leads Lynn Hadaway Associates, and she holds dual national certifications. She also has multiple, over 75 published articles and 8 textbook chapters, and she's well respected in the field. She's also on the INS Infusion Team Task Force, and she has received accolades like the Herbst Award and Distinguished Alumna Recognition. She's a respected leader. They're all respected leaders. We're very, very grateful that they could come and talk to us today. And the topic is the development of an evidence-based list of Vesicant medications and solutions. So please take it away. Thanks, Lisa. You're muted. Lisa, you're muted.
Sorry about that. Okay. All right. Thank you, Gillian, for the nice introductions for all of us. So we're going to talk about our evidence-based list of vesicant medications and solutions. The objectives being to identify vesicant med solutions, examine issues associated with peripheral vasopressor administration, and specific issues associated with midlines. So I'm going to launch things off and really kind of go through our list and some of our processes with development of that list, and then Barb will follow talking about the peripheral vasopressors, followed by Lynn in the midline. So I'm going to go relatively quickly here. We know that knowing which drugs and solutions are vesicants is really the absolute first step in preventing extravasation. I put this slide up here. I don't know to what degree legal issues and malpractice happens in Australia, but it's not uncommon here. For myself and Lynn, much more so than myself, we reviewed a lot of cases of extravasations. And one of the fundamental things, and these are just some quotations, I'm not going to read them all to you, you can see them on the screen, but clearly when you review these cases and you listen to the depositions of the nurses, none of these nurses want this to happen, but they truly lack knowledge. They just didn't recognize that the drug they were administering could cause damage like this, didn't respond rapidly to obvious signs of an extravasation. So
that's what we really have to get at, is really helping nurses to understand the dangers of some of these medications and solutions and what can happen. This is just a list of our task force members. I chaired this committee for our 2017 list, and am chairing it again with a relatively new committee. Kathy remains on the committee, and then everybody else is new. So I was really happy to have Lynn and Barb joined the committee, and we started this in 2021 and really got slowed down with Barb and I especially being on the standards committee. So hopefully we're wrapping everything up now and getting it ready for publication. But our goals were to update the 2017 list, identify, what is the current issues that we see in practice. And we have an extravasation prevention checklist as well. That sits in the INS website. We have updated that, and that is accessible to everyone, even if you're not a member of INS. One of the things that happened early on in our committee is we really had a lot of discussion about the fact that we are increasingly administering vesicants peripherally. Certainly you can get extravasations with central lines, but the risk is far greater with peripheral catheters. And then we have the whole issue of midline catheters as well. And we have differing definitions. We have problems with blood return in midline catheters, issues of intermittent versus continuous, and just that need to better understand outcomes and complications of midline catheters. So that actually led us to actually doing a separate paper. Lynn and Barb involved on that. My main focus is this paper, but kind of working in both areas a bit. So we are actually in the process of getting 2 papers published, hopefully in the same issue of the Journal of Infusion Nursing. Methodologies, just very quickly, re-examining those systematic and narrative lit reviews that we looked at in 2017. We identified updated lit reviews. We retrieved and reviewed cited case reports, and then we did individual lit searches for all of the drugs that we potentially identified as vesicants. We resourced primary drug references for drug-related data, osmolarity, pH, etc. And this time we also reached out to the FDA adverse event reporting system. We identified some drugs where we have a little bit of uncertainty, were there reports to the FDA. So we did those searches as well to be very thorough in our methodology. We go through the mechanisms of tissue injury that are contributors to extravasation. Again, I'm not going to spend much time on this, but non-physiologic pH certainly is a factor. Hyperosmolarity and even hypoosmolarity can be issues as well. Vasoconstriction, certainly mostly in the area of the vasopressors. Cytotoxicity, we didn't talk about that with 2017, but we now know that some of these non-chemotherapy drugs are also directly cytotoxic. Vancomycin certainly being one of them. We always understood it to be primarily a somewhat acidic drug, but now it's understood to be a cytotoxic, and there's a few others as well. But vanco is the most well-studied. And then we have absorption refractory. Now, this was proposed by Jenny Ong and Ruth Van Gerpen, who are also on our committee. And they proposed this as a 5th mechanism of tissue injury. And it relates to, lipids sitting in that interstitial space. They have a limited ability to be absorbed in the bloodstream. And I can tell you that propofol really is the leader here. We have a lot of cases of propofol extravasation. I have actually a terrible one right now that I'm actually reviewing on behalf of a plaintiff. So we looked at these mechanisms. We've outlined all of that in our box and will be in the paper. And then in 2017, we identified kind of a red list and a yellow list, high risk, a cautionary list. We recategorized our vesicants for 2021 and tried to become much more objective, okay? So high risk, we're looking at least 2 cases where there's evidence of permanent functional impairment. So we're looking at the reported cases and what type of damage it could result in, okay? Could be, permanent nerve damage, loss of limb, etc. Moderate risk would be at least 1 documented case of injury in a valid proposed mechanism of tissue injury. So we know why it caused the extravasation. If there's a single case of permanent functional impairment, we rated it here. And then we have cases where there isn't permanent scarring, but some some subcutaneous tissue damage. It may be minor scars. And then drug instructions for use. We added this a little bit later when we looked at the IFUs, looked at verbiage that indicated reports of extravasation and necrosis. So we're looking real specifically for those words in the descriptor. And then we have a cautionary list as well. These may be either a single report, but we don't really have a good valid proposed mechanism for tissue injury, or we have a potential mechanism, but no case report. So we really need to keep an eye on those. And sometimes we have a lot of confounding administrations of perhaps more than one potential vesicant at the same time. And those are on our cautionary list. So now I'm looking at my time here. I'm just going to go through the list relatively quickly here. In terms of our vesicant list, we retained the 4 drugs on the right side from 2017, and then we added 4. Now, we did look more globally this time, so we included tetracycline and flucloxacillin, and these are drugs that are not administered in the United States. And azithromycin and remdesivir. I actually pulled a photograph of remdesivir. I just kind of thought about this one. It's a more recent drug, obviously, in the context of the COVID pandemic. And several cases of extravasation. And one point I always like to make when we look at that.
Extravasation.
I'm sorry. I heard some talking. Okay. Anyway, you know, as we think about these antimicrobials, I mean, we aren't looking just at hospitalized patients. These are drugs that are given in outpatient, perhaps home infusion, et cetera. So we have to have a lot of awareness. Certainly the majority of the vesicants that we're talking about are administered in acute care settings. But the remdesivir was pretty significant there. What was interesting in these cases, all of the cases that are cited here, all in very small veins in the hand or the wrist, certainly has some applicability there in terms of selection of the right device and the right vein. Then we have our electrolytes and nutrition. I'm not going to spend a lot of time here just because I have limited time, but we expanded this list. We added some new things, lipids, you know, again, due to that absorptive refractory tissue mechanism. We have cases there. Now, all of the cases with lipids were within pediatric and neonate or pediatric cases. So definitely more in that patient population. And if I look across the board at our entire list, we'd certainly have a good number of extravasation case reports in our pediatric patients. And we do address that in our manuscript as well, some of the risk factors with our young kids as well as our older adults. And then we've got our cardiovascular list, mainly oppressors, but we have acetazolamide, you know, a significant diuretic there as well. So we added to that list. Sedatives and anti-epileptics, we did add 3 new drugs there. Again, based on cases, and propofol, again, as I mentioned before, really does stand out because we have a large number of cases associated with that drug, not just extravasations, but also compartment syndrome. And we do address compartment syndrome as kind of a separate category because obviously that can happen with any type of medication, not just a vesicant drug. And just a little bit more information here. Now, thiopental is, again, a drug that's not available in the United States, but it is recognized as a cytotoxic drug. So it's another drug that falls into that category. And then we have our other list. And new to the list, I'll focus a little bit on contrast media, a lot of cases there. We tried to break those down in terms of, you know, extravasation injuries and as well as the compartment syndrome, which is really quite prevalent with contrast media. Drugs like fluorescein are relatively narrow drugs used in eye exams, for example, and IVIG is new to the list as well. We certainly give a lot of IVIG, and there are certainly a multitude of formulations of this type of infusion. And so there's, you know, a lot of variation in terms of pH levels, osmolarity, et cetera. But in general, there are extravasations, again, high number in children. Iron sucrose, moderate. And the biggest issue with iron sucrose is some of the long-term staining and scarring associated with the iron formulations. Most of the data we could find was specific to iron sucrose, but if you look at any iron formulation, that's certainly a risk. I'm going to skip that slide in the interest of time. It just gave a little bit more detail to the previous list. And then this is our cautionary list. Again, when we publish this, everything is tabled out. We have our high and moderate list. We have our cautionary list with all of the supporting data in terms of the potential mechanism of tissue injury, or if there's none, and examples of cases and why we concluded that. And we have a number of authors' comments in that table as well that really kind of substantiate what we were thinking in including these drugs on the cautionary list. Limitations, clearly, it's established based on lit reviews and case reports, and many of these case reports are old, and we know that extravasations are underreported. Lynn certainly sees a lot of them. I do too, but they don't tend to be published. And, you know, the older citations may be less relevant as well because there have been changes in drug manufacturing methods. And when we look at the case reports, not all of the case reports are fully analyzed. There's often a lot of questions. We have one example of a Banco extravasation that is really quite questionable. And I did reach out to the author of that paper without response. And again, extravasation cases are more often than not reported in the formal literature. So with that, I am going to stop my share. So sorry I had to talk so fast, but I'm going to let Barb take over. And okay.
Hopefully everyone can hear me. Again, this is Barb Nickel, and the section that I'm doing on this paper is on vasopressor administration, especially peripherally. This is a passion of mine. I've published on it many years in critical care, and really speaks to the fact that we do need a way to deliver vasopressors safely when a central line is not in place, either because they need the pressor so quickly that we don't have time, or maybe that it would be unsafe to place it. And so again, this is an area of practice that we do need higher quality of research in. There is quite a bit out there, and we have included an evidence table on peripheral administration of vasopressors in the non-cytotoxic paper. So we've also included guidance now in the new standards as they come out. So hopefully those things will help, and I'll give just a high-level review of what the evidence says in this particular area. So again, our interest here is safe delivery of peripheral administration of vasopressors when we can't use the central line. The central line is still the preferred route for continuous vasopressors, and if it's in place, it really does need to still be used as long as it's patent and well placed. Unfortunately, and I can speak to the United States, and this is just very prevalent, there is a shift from central to peripheral lines, and pressors really have gotten quite a bit of that emphasis because we want to avoid CLABSI in the central line area. And facilities are using peripherals as a CLABSI prevention strategy without really a good knowledge of what the risks are, the patient harm that may be resultant from that particular strategy. And so that's really what we want to speak to, because there are harms that can be caused even when we're trying to avoid a CLABSI. So we are going to, and I'm going to do, as I said, a high-level discussion of this. Basically, a summary of the studies is that, yes, it can be done peripherally, vasopressor administration, but it must be done very intentionally and with clear safety parameters. I've given a smattering of some of the pressors that I'm talking about. I don't know exactly what's used in Australia, but I assume many of these are in place for you. Norepinephrine obviously is used quite extensively in sepsis. I've even included the dirty epi on the right-hand side. I don't know if that's used in Australia, but used quite a bit in our ERs when someone's responsive to epinephrine. Just throw a milligram vial of epinephrine up into a bag of normal saline and just deliver it wide open. And so again, including all of those particular possibilities. So the statement that we'll include, this may not be an exact quote, but it really represents the content not only of the non-cytotoxic work, but also of the new standards, consider vasopressor administration via a short peripheral IV catheter. And that, I'll speak to that. That's still going to be the recommendation. And the studies really talk to 24 hours or less, especially in the adult. The preponderance of the evidence is really in the adult population. There is some evidence for children, but it is not strong as is usual for pediatric research. It's just difficult to get data in that population. Again, if the central line is not in place, that's when this should be considered, and really should be short duration. Risk of extravasation appears to increase with the duration of the infusion. So, and that's logical, but it's also supported by the research. So that's what we need to really focus on, is those patients that we feel are going to have a short duration of hypotension, or maybe are just minimally hypotensive, but we feel like we're going to be able to resuscitate them fairly successfully. I have 3 systematic reviews on that evidence table that I mentioned. That do include both adults and children. Mean duration of peripheral infusion of pressors ranged from 12 to 25 hours, leading to the conclusion that there's really insufficient evidence to say that greater than 24 hours is a safe practice. This, what I'm going to do is just reiterate, we need higher quality of evidence to tell us what is the safety parameters that we need to use, and how long can this be done, and in what type of vascular access device. So a quick look at the current state of evidence. And as I mentioned, there's a full evidence table. This is just a quick timeline really of the evidence, but the current state on the left-hand side of the slide, again, an urgent need for high quality studies, prospective research, because there's so many limitations to peripheral vasopressor research. There's so many limitations to peripheral IV research in general, a preponderance of retrospective studies, methodology, which is reliant, of course, on accurate documentation, which has been well established that it just really is not of high quality when it comes to peripheral IV status on insertion throughout maintenance of the line all the way to removal, and why. We also have really an inconsistency in knowledge within nursing on how to recognize extravasation, how to call it correctly. Many of our EHRs just list symptoms, and that's what nurses define. And so to say that we really know our extravasation rates is really, I think, not a strong statement that we can do. I really think that if we had better documentation, that our extravasation rates would be alarming. There's high heterogeneity in both methodology population bases within the studies, high risk of bias, and inconsistent reporting of study characteristics. So again, the generalizability of these studies is problematic. Unfortunately, people cherry pick these studies and say, well, if they did it, then we can do it here. But they don't really look at the details of the study, and then they don't replicate them well at their facility. So again, those are limitations that I've seen as I've talked to representatives from facilities from the United States. The Cardenas-Garcia study at the top was one of the early ones, single center observational, over 700 patients, 49 hours of duration, 2%, or I got to move my Brady Bunch box here just a second. Whoops. That was 19 patients that had extravasation. The Lubani study, it's a systematic review, really was when this started to really pick up steam. There was enough studies to do a systematic review. And their recommendation has really been cited in some recent publications, including the severe sepsis guidelines, stating, they say, actually, PIVC may be used emergently for less than 2 hours, but it has to be well placed and proximal. And I'll talk to that here shortly. The TRAN meta-analysis was a good study also that gave us a great deal of guidance. 9 studies there, 1,800 patients. Unfortunately, they said 7% complication. That represents 122 patients. In this study, they called those minor complications infiltrations. Those were actually obviously extravasations. Many of them did require treatment. Their major complications were thrombus in that particular study. The Spiegel study, you can see in the middle that they had a variety of midlines represented in that study. It was prospective, that was helpful, 400 patients, and they looked at a broad application of midlines that were started in the emergency department. 29% of these midlines were used for pressors. The one that required plastic surgery had norepinephrine infusing. So again, the major complication was a pressor delivery. And then the Prasanna study is one that's cited many times in the United States as proof that we can give them in the midlines. About 250, average duration, almost 7 days. And they said only one extravasation, but again, weak evidence because it was retrospective. We need high quality evidence to really say, is the midline the right method to deliver? And so a good example of extravasation risk, this 47-year-old female, she had a central line in place and they felt they had to place a peripheral as well. Multiple products given. I won't read all those off, but inotropic support was one of them. In the study, and this is one of the weaknesses that Elisa also pointed out, you can't really say what was going in this peripheral line versus what was delivered in the central line, but obviously a vesicant was given in this antecubital space. PIV was removed. 2 days later, she started developing a blister at that site that then became necrotic, required debridement, ligation of her basilic vein. Obviously, that's going to have lifelong ramifications for vascular access therapy, significant scarring, again, from extravasation. So the risk is real and it is delayed, and that's part of the risk as well. So I will quickly go over what the research shows are strategies that can reduce extravasation risk in peripheral vasopressor administration. And they fall under these broad categories: boundaries for dose and concentration, VAD selection, and then escalation or de-escalation to the right vascular access as fast as possible. Patency I'll touch on because that's very critical. Site assessment, and then once it's recognized, the use of decision tools such as staging and to assist in provider notification, and then treatment protocols, just making sure that facilities do have those proper treatment protocols in place, and then looking at the quality of documentation so that then we have data that can inform process improvement. And then throughout this is all staff training, competency, and then truly monitoring outcomes. When I talk to facilities, when I consult on this, what I hear is, well, we've been giving it in midlines for years and we don't seem to have any problems. And my question to them is, have you really monitored your outcomes? Do you truly know what your extravasation rate is? And many times the answer to that is no. So those general recommendations, again, our staff need to be trained in protocol use, and there has to be a clear protocol. They have to understand what extravasation looks like, how to recognize and quickly treat. The many studies represent the fact that if there is a safety protocol in place and it's well adhered to, that is associated with improved outcomes. Unfortunately, there is still insufficient evidence. There is insufficient evidence to construct a bundle, but again, we give recommendations here in this document and also in the 2024 standards. Some of those recommendations that are represented, again, are 24 hours or less, and cases that have anticipated short duration of pressors. So if I'm taking care of this patient and I'm rapidly escalating in my first pressor, and I think I'm going to start a second, that's not somebody that I'm going to stick with a peripheral site. That's somebody that I need to escalate to a central line for. One pressor per peripheral site, which again is not happening in many facilities. Lowest possible concentration, obviously with a pump to protect and deliver accurately and safely, and then as close to the insertion site as possible. VAD selection, obviously good hemodilution. There is another midline study, the Gershongren study, that has more rigor than the Prasanna study, still retrospective, but they talk about the fact that norepinephrine can cause thrombophlebitis. And that seemed to be one of the surprising findings of their study. We need to avoid areas of flexion. It may be required because that's the only vein we can find and we need to resuscitate quickly, but then we need to recite it as soon as possible. And this is where, referring to Labani's study, several publications have fed off of their recommendation to cite peripheral administration of pressors proximal to the AC or use the external jugular, which would not be a good choice because they're difficult to secure. But many places think proximal to the AC would lend to be maybe a midline placement. That wasn't, though, what Lubani and that group were thinking when they made that recommendation. They were really saying that anything distal to the AC in a hypoperfused patient increases the risk of extravasation injury, increases the severity. So they were saying it can't be distal, just more for site selection than actual vascular access device selection, again, to reduce the risk of injury. We need to, again, evaluate regularly to escalate, de-escalate, and the recommendation in this particular document is, again, not to use the midline catheter or a deep, long peripheral catheter for continuous vesicant therapy, vasopressor therapy. Number one, because there is insufficient evidence to support it. Number two, because recognition is going to be difficult based on the extent of tissue damage that it would take to come to the surface. And if this is a hypoperfused, sedated patient, and I don't have blood return in this site, then it's going to potentially be a very extensive injury before I would recognize it at the surface. So that's a good segue to patency. Just quickly mention this. Occlusion obviously happens in both peripherals and centrals, and for similar reasons: thrombus, catheter damage, vessel damage, or spasm. And we have clear definitions in the central line. I have those listed here based on the INS definitions. I won't read those, but we have a clear requirement for blood return, positive blood return, prior to giving a vesicant in a central line. And we have a way to treat it if that isn't present. Unfortunately, though, occlusion is poorly defined in peripherals, we don't have a way to even restore it if we would need to, and that could be potentially problematic. And we really have a high reporting of it in research study, occlusion being a very common complication within peripherals. So how do we give a vesicant safely in a peripheral where we can't obtain a blood return? That is something that we've really wrangled with, and I think we've stated in a more clear, succinct way in the new standards. But our recommendation in the non-cytotoxic vesicant paper really is, if we don't have a good blood return in a peripheral, that isn't a good choice for a continuous vesicant solution, including pressors. We really need blood return to establish patency in that line. If it's not present, then we're increasing risk. Site assessment, we need to monitor it closely. Every hour is likely needed if we're giving peripheral vasopressors. That can be difficult to document, so we need to work with our system to make sure that is something that our staff can do within their time frame. We need to do it by palpation inspection. We need to look for patient complaints if they can offer it, skin temperature, all of these things to make sure that the site is within defined limits and truly is functioning and is patent. And keeping in mind that during transfer, in the second indented bullet point, this is a cross-sectional observational study, patients in this study had a 9 times higher risk of adverse events such as extravasation if pressors were given during an intra-facility transport, say between ED and ICU or ICU to radiology. So again, site assessment really critical here. Device detections detection devices can help. Again, that's an area that's we need further study on and further refinement on how those can assist us. We can't rely on them completely, but they really can help on patients that are difficult, such as prone patients. So I've given just a couple of quick examples. This is a table that was in Jenny Ong and Ruth Van Gerpen's article that Lisa mentioned. Again, both of those are on our task force. They include staging criteria. This is not a validated tool, difficult to validate a tool in such a random complication as this. But again, with further study, I think this could really become a very helpful decision tool. It helps the nurse to stage the severity of the extravasation on first recognition, and then assist in the ongoing evaluation to say, is it improving or is it getting worse? How quickly do we need to escalate provider notification? And then what do we need to ask for as far as treatment goes, as far as an antidote? And then I've given an example of a treatment guideline on the side. This is one we've developed within my system, where we have all of the drugs listed that have any evidence of treatment if it gets into the tissue. We've also then designated, is it a vesicant or not? Does it have phlebitic risk? And then what is that treatment? So these are examples of a couple of tools that staff need at their fingertips if we're giving peripheral vasopressors, to make sure that they can recognize, notify the provider, and get the correct treatment as quickly as possible. So with all of that being said, a quick summary statement at the top: when the urgency of clinical treatment drives vascular access selection, we have to monitor our outcomes, and we have to do that effectively. Unfortunately, I know in this country, there are places that are not effectively monitoring because there's so many pieces to this puzzle that are not yet in place. Staff competencies need to be in place to pick the right vascular access device, to truly monitor and in the right frequency, recognize and treat. We need to build documentation and event reporting that aligns and guides best practice. And that then creates a reporting structure that allows us to truly say, what is the patient harm here? What really is the right avenue to deliver vasopressors safely peripherally? And then once that data comes forward, we need to publish those outcomes. We need to publish case reviews as well, because that's really where we've come to understand this area of practice so well. And so that is my section. I'm going to now hand it over to Lynn. I'm going to just stop share. And there you go, Lynn.
Thank you. All right. Well, first, I'd like to say thank you to Avatar for actually making this possible, because without access to the Griffith University Library, all of this research would have been most difficult for me. So thank you, thank you, thank you. After we started this work on vesicant identification, and it became obvious that there was a difference and a lot of questions about midlines. If you look at the published rates that you see in a couple of the studies, there's another question about the definitions of infiltration versus extravasation. On the pediatric and neonatal study, they use the word extravasation, but Helms uses the word infiltration. So there's plenty of concern when you start looking at the evidence about how they're using those words, and is everybody sticking to the same definitions as what we have in the INS standards of practice, and it's obvious that they're not. So it's hard to discern these rates of infiltration versus extravasation, the oncology drugs versus the non-oncology medications. ONS has given a lot of attention to the non-oncology medications, and this, or to the oncology, and then this would be the non-oncology. The questions about midlines drove a lot of concern, and we've seen a radical shift away from central lines over to using midlines, primarily because of the financial aspects of it that CMS imposes upon hospitals here in this country. Come on, there we go. So let's look at definitions first for a midline. When you look at all of the organizations that have written a definition, there's a great deal of difference. The INS definition is one inserted with the tip lying near the axillary fold in the basilic, cephalic, or brachial vein of adults. We also have a definition for children and neonates in the INS definition. WCOVA, on the other hand, the World Congress on Vascular Access, has a definition based on the catheter length. They refer to a long peripheral catheter as one being 6 to 15 centimeters long, while a midline is one that is greater than 15. And, oops, sorry about that. Their tip location is anywhere in this axillary subclavian region. So anywhere along that axillary subclavian vein is fair game for their midline tip location. This is causing a lot of controversy and a lot of confusion between the INS definition here in the periphery versus these veins that we have always regarded as being in no man's land, if you will, for a tip location. That was probably based on a severe bad lawsuit here in this country back in the 90s that was really bad outcomes for a mid or for an axillary tip location. MAGIC, on the other hand, uses a term that's, they have a definition that's very broad. They do include lengths, just like Wacova, but they include everything from 7.5 to 25 centimeters inserted in the antecubital fossa, residing in the basilic or cephalic vein, terminating just short of the subclavian vein. Okay. Fortunately, Mini-MAGIC's definition of a midline is the same or very similar to the INS definition. So that's the second problem. First problem, difference between infiltration and extravasation. The second problem is how we define a midline catheter. So that brought us to the need to do a literature review. In this literature review, I found 7 different systematic reviews and meta-analyses, and of these 7, 6 of them had included studies with both tip locations. So you really can't discern in these meta-analyses, you can't really discern, is there a difference between midline and what I would call mid-clavicular? Back in the 90s, the INS developed a task force, and we at that time decided that this axillary tip location would be called mid-clavicular. So that's what we're going to be referring to, that tip location, how we're going to be referring to it in this paper. So when you look at these meta-analyses, the CRBSI, no statistical difference between the midline and a PIC, but again, midline is either of those tip locations. Phlebitis rates, no significant difference. Thrombosis, higher with a midline than a PIC in certain countries, but not in others. And then Tripathi looked at all complications, DVT, dislodgement, infiltration, occlusion, phlebitis, kind of everything in that one. So I've separated it in this paper. We've separated these meta-analyses and have looked at only individual studies. And we made an attempt, based on what the author's descriptions were, we made an attempt to segregate the midline definition according to INS and the studies using the mid-clavicular tip location as similar to the Wacova definition. We found there will be 44 studies total in the evidence tables, 36 from midlines, and 8 from mid-clavicular. As you can see, the level of evidence for the midline tip location is relatively low. Maybe because midlines have been out since 1989 when the first commercial catheter was introduced. The Wacova definition has not as many studies, and only the one that's the low level 5. And these levels of evidence is the same as what we have in the INS standards of practice. So when you break down these studies, in the midline group, 30 of 36 studies reported infiltration and extravasation. Again, we don't know how they're using that term. And 7 out of 8 of the mid-clavicular catheters did report infiltration and extravasation also. In the midline tip location, the one that I pulled out here, a couple that I pulled out, the trans study reported 20 out of 300 or 7% infiltration, and 9 out of 300 or 3% extravasations. That was one of the only ones that did distinguish between those 2 complications. They did find higher rates with DIVA patients and higher rates of failure with norepinephrine. And then all of those studies listed there focused on higher rates of failure with high dose concentrations. Mid-clavicular data, not so easily identified, not as much of it. There is a study from back in 2013 that reported that tips outside of the IBC, SBC, or right atrial junction was associated with an increased complication rate and even complications after removal. It was pretty striking to me that leaking from the puncture site was predominant. That was throughout all of these studies. 3 of 8 midclavicular studies, and 2 studies actually defined leaking from the puncture site as infiltration. So that they're looking at it, most of these other studies are looking at it as a separate complication, or they're labeling what I would consider a sign of a complication, not a complication itself. 18 of the 36 midlines reported leakage, and the Myers study was the one that gave a little more definition. 9.7% reported leakage, but they went on to define that it occurred at a median of 8 days. That was the only one that had any further data on the leakage. So these studies had no effort to diagnose the problem, and it was just grouped as minor complications in most studies. There we go. So that brings us to a lot of different clinical decisions that have to be made. As Barb mentioned, the loss of blood return is quite common. It's seen in midlines between 3 and 4 days. So that could be technique-related problems with aspirating with a large syringe versus a small syringe, or it could be vein thrombosis, which is a very high rate in midlines and midclaviculars, or it could be infiltration and extravasation. So how are we going to assess patency if we don't have a blood return? The ideas on the table would be, of course, to use some type of visualization. That would usually be limited to ultrasound for the deeper tip location of a midline and a midclavicular. Near infrared lights are usually only applicable to superficial extravasations in a superficial vein. So, vesicant administration through a midline right now and a midclavicular right now, the INS says do not do that. Do not use a midlines for continuous vesicants, parenteral nutrition, or extremes of pH and osmolarity. Well, that brings us to the discussion of how do we define continuous infusion. So that's a lot of confusion out there about that amongst nurses in this country. So we have defined continuous infusion as a controlled method of intravenous administration given over several hours or longer without interruption. So you may have a brief flow interruption when it's clinically indicated, such as pump alarms, patient complaints, edema, redness, leakage, that kind of thing, while you assess it. But continuous infusions should not be stopped. And unfortunately, in this country, we have a problem with continuous infusions being stopped. Patients got to go to the bathroom, they got to go eat, child needs to go play, they just stop the infusion. Intermittent would be something, a small volume over a shorter period of time, and then use of the injection port. A lot of nurses think that to check for a blood return, you need to disconnect the continuous infusion, but that's not the case. You can use the injection port on the administration set itself. For vesicant administration through either of these tip locations, the depth of the vein is a major concern. So when I looked at that literature, there's very little studies out there reporting the actual depth of the veins that we're using. A couple of studies, I think one looked at, was from a pacemaker insertion type situation. Axillary vein at the deltopectoral groove ranges anywhere from 28.5 to 38.4 millimeters. Mid-humerus, though, where we're putting in the midlines, the insertion site, would be a depth of 15 millimeters, and then the mid-forearm is a depth of only 3. So with those deeper veins and with this concern about leaking in so many studies, are we seeing the same signs and symptoms of infiltration and extravasation that we see in superficial peripheral veins? Can we translate that over to a midline and a midclavicular and just go our merry way? Or is there a different clinical picture with these deeper veins? And that question has not been answered yet. So vessel health and preservation, of course, is our priority, with a minimum number of catheters to be used. And when the nurse is faced with the choice of what catheter they're going to put in, they have questions to answer, and a lot of them, I think, are not knowledgeable of these different considerations. If you've got how many compressible veins in the upper arm do you have? If that first midline fails, then do you have another place to put in a midline, or is it going to result in complications with getting in a PIC if you want to switch to a PIC? And then the vein diameter at the midline and midclavicular tip location is definitely less than the superior vena cava. So what does that mean for the peripheral therapy that we have been giving through peripheral veins versus central veins? A lot of confusion out there. Another point of confusion in the study, in the standards, we used anticipated length of therapy versus maximum dwell time. There's lots of confusion about that. Anticipated length of therapy is what you know at the beginning. When you've gotten the prescription, you're assessing the patient, you take you include the look at how long this therapy is planned for. Maximum dwell time is something totally different. That's what we see from the studies, but we don't have a maximum dwell time for any catheter that's available on the market anywhere. Midlines, according to the INS, midlines should be chosen for therapies between 5 to 14 days, and it's a component of that initial VAD planning assessment. But we don't have a maximum dwell time. It is unknown for any catheter. Many of you may have seen the 30 days that is written in different formats, different ways, different languages, or different wording on some of the devices. That represents a short-term category of catheters. It does not actually refer to dwell time based on clinical outcome studies. It is a definition of a short-term catheter that the manufacturer provides to the FDA when they're first submitting this for clearance. So we have a lot of questions and a lot of more evidence that is needed. Is there a difference in the clinical outcomes between a midline and a midclavicular? We don't know. The infusate characteristics that are capable of producing the optimum outcomes through each of those tip locations, the safety of continuous infusion of vesicants through each of those tip locations, the clinical picture of those, as we mentioned, and then the methods to assess patency. The work by this Vesicant task force also looked at creating a checklist for all across the board, everything. So we started with what the organization should do with their policies, protocols, a written list of their vesicants, their restrictions on vesicants by VAD type. It also includes competency assessment and documentation, standardized processes for documenting in the medical record, and then the emergent access to a treatment plan with antidotes and thermal packs. Pre-administration assessment for peripheral catheters, there's a list of factors there that is on this list. We'll have time to go into each one of them. Another section on pre-administration assessment for central vascular access devices. And then how do you actually safely administer, and the list of criteria there that's included. I believe Lisa said this, there is a section on CVAD vesicant administrations too, because it can happen, extravasations can happen from a CVAD. I believe this checklist is now available on the INS website, according to what Lisa said. So we did go a little bit further than the standards have in the past. If we have no blood return from a short peripheral catheter, we want to do that careful assessment of the patency and confirm with your ability to flush without evidence or swelling, pain. If all of those signs and symptoms are absent, but you don't get a blood return, then the nurse has to make a decision about, is it safe to use this catheter? But when you're talking about a midline or even a long peripheral or a midclavicular, this checklist says do not administer a vesicant when in a deep vein when the early signs and symptoms of extravasation may not be as easily detected. So, and then there's the list of all the signs and symptoms that are on that checklist. So, just a synopsis of what all is included on that checklist and our references. So with that, we can open it up for questions. I'm not sure what time it is. I'll stop sharing. And how much time do we have left? About 5 minutes.
Oh, thank you. Thank you so much. Both,
You're welcome.
all three of you. That was amazing. So we're so much information. Oh my God. So a couple of things I just want to ask first. Are you able to share your slides? Is that possible or not? So that we
Sure, I don't mind.
can have a little read.
No
of them.
problem.
So
Yeah.
if you could send me your slides, that would be really kind, so we can send out a PDF to the folks so they can have a little read. Did you have an estimated publication date for this work?
Yeah. Hopefully, you know, I'm talking to INS. These are two big papers. Okay.
They both are very high in word count and big tables. So, you know, we're hoping that they'll be able to publish everything.
Lisa.
What?
Lisa, sometimes your microphone is going in and out.
Oh, okay. I'm sorry, I should have worn my headphones. Is this better? Should I talk closer? Okay.
And that's worse.
In terms of publication, we're still finishing the papers. I've been working on it all day actually on it. So hopefully we're getting very close to that. We've got a couple of people that we want to review it first before we send it in. INS wants to publish our paper. Obviously, it has to go through the peer review process. So I'm thinking optimally, January, February, March, April, probably the May, June issue is probably the most realistic. You're still not hearing me?
No, not easily.
Oh, okay.
It's
Okay.
not great, but May, June, hopefully we'll see it in print. Excellent.
Yeah, I'll happily turn off my video if that helps with the audio. But yeah, so hopefully we'll get those in the process soon. It just with the INS standards really slowed everything down.
Oh, absolutely.
Yeah.
Massive amount of work for you guys.
Yeah.
Incredible.
It became overwhelming.
Yeah, I'm sure. Does anyone online would like to raise their hand and have a question? Because if not, we have lots of chat going on here, which it was fun to watch. Anyone got a question? No, not at the moment. Evan put something up that I didn't see a response to in the chat. I wonder if patients with chronic disease who likely have impaired endothelial function are at higher risk of extravasation. Is there anything about you know, your patients with your liver disease, your kidney disease, etc., that we know of? I know the evidence is patchy and it's all, you know.
Mm-hmm.
None of the studies that I reviewed on midlines included anything like that.
Okay.
Yeah.
I think that is where we need to study, though. I really think, especially in critical illness, where we are using more and more midlines, and I think we're seeing those outcomes. What is it from? And I would agree with you. I think your endothelial function has a great deal to do with it. I don't know if you're going the glycocalyx route. I'm sorry, Lisa, just said, I don't know if you're going the glycocalyx route. Yeah, that's what we need to understand. Exactly. And what are we delivering and how does it impact that when it's already impaired? Yes.
Yeah, there seems to be there's been a couple of papers around COVID and the deterioration of the glycocalyx and endothelium with that chronic inflammation and compounded with chronic disease. So it'd be interesting if patients do have renal disease, diabetes, all these sort of chronic and complex problems, whether that if they've already got that endothelial dysfunction and, whether that increases the irritation of the endothelium and sparking off that inflammatory response.
Mm-hmm.
Yeah, I wonder if there's some kind of a screening we can do for that.
There are biomarkers actually that they've developed. We're sort of starting to delve a little bit into it with one of my PhD students. I mean, Andrew Bulmer's probably all over it. But yeah, I think that's probably one thing we're thinking of doing if we could identify a particular biomarker, whether or not, let's say we did place a pick or a midline, if we did serial blood collection, whether or not we would see those biomarkers increase, which could potentially be telling us that we are getting that, irritation occurring.
Andrew, everything that I've read focuses on arterial rather than venous. So anything you can add to the venous endothelium situation would definitely help.
Yes.
Yeah, that's a really tricky one. You're right. The vast majority of the work's been done in arterial biology due to the risk of atherosclerosis and the importance of the glycocalyx to preventing that process. So, yeah, look, I think there's a lot to be learned in that area. I guess I don't have the answer to the question. But, certainly coagulation status, if we refer back to Virchow's triad, we can look at some of those parameters around hypercoagulability, but also potentially areas of damaged endothelium. So if we do suspect that an area is damaged, in some of our early phase clinical trials, we could potentially draw blood proximal to the site and pick up markers of endothelial damage. So this glycocalyx protein that's located on the inner lining of the endothelium, we could potentially draw blood and look at the concentration of it to see whether it's being released. But yeah, it's a tough one, and there's a lot of inflammatory markers that we could also measure, but it has to be specific to the site. You can't just measure it systemically, otherwise you could be picking up other signs and indicators, Evan.
Yeah, exactly.
Could I just ask one quick question to Lynn? Might be controversial. Now, don't spank me, Lynn, when I ask this. Your thoughts are, because we moved away from trimming our midlines, and we terminate them at your long, soft 20 centimeter type midline. We terminate them mid-clavicular for non-irritant, non-vesicant medications. And we seem to have less problems between those and the ones we trim and left near at or just below the axilla. We found we were getting more problems with thrombosis, leaking at the site, etc. when we had them in the arm, sort of terminating just below the axilla. Yet once we moved to that sort of mid-clavicular region, we found we're not getting as many problems.
Well, that's good to know. And the difference in the volume of the studies is not going to answer that question for us yet. So the more you can do, the more you can publish, the better it will be. Years ago, when this big lawsuit happened, this major lawsuit, we were fighting the battle of picking an SVC versus mid-clavicular. So NAVAN, which was Ava at that time, or Ava, which was NAVAN at that time, wrote a position paper in opposition to the mid-clavicular. The mid-clavicular never made it into the INS standards because we didn't have any studies to support it. And then this big lawsuit blew up, and we just kind of didn't focus on that. And we focused on the axillary tip location. So that's where the volume of evidence is located. But I would encourage more definition, more studies on all of those questions about both of those tip locations. I've got a question. I've always had these questions about the convergence of blood flow in that axillary vein from the cephalic vein coming in, the other external jugular veins, joining the axillary vein there, and the fact that it's basically horizontal, and how can the tip reside in the center of the vein without impinging on the vein wall as easily as it can in the midline tip location? That's another unanswered question. So there's plenty of work to be done.
No, I agree. I mean, it's there's more there's more studies starting to come out around as you said, like, around mid-clavicular placement. I know that's something that Vineet Chopra also favors, and as you know, like Mauro and the Italians. But it would be good to do eventually like a multi-site RCT looking at this. I think that's what we really need. Across many centers, and I think across the world, like, because North America has a certain sort of thinking, we're sort of all over the shop here in Australia. We'll go, we'll go either way. The Italians, they've got, they'll shoot you if you trim it, so I think it'd be good to, do a big study across multiple centers to get some good data.
I just found
Can I just throw in one question?
Yeah, go ahead, Lisa.
Yeah, so, looking at the mid-clavicular from the past, because that's where I first came in. I was placing mid-claviculars all the time. Okay, that was what I learned, and then everything fell apart there. And one of the questions I often have is, why are we having more success now? Does it have anything to do with the catheters itself, the type of catheters that we were using all those years ago, the composition?
But you mean like the Aquavine that was originally being used?
No, don't go there.
It was,
Don't
no.
Don't go there.
It was,
don't go there. No.
No, because I know what you're talking about, but I'm talking about using picks and placing them mid-clavicular. The composition of the catheters at that time are things, I guess that's a question that I often have.
Silicone versus polyurethane was...
Yeah, well, the polyurethanes, we were mainly using silicone back then, which is generally pretty compatible.
There were some polyurethanes coming, and polyurethane
yeah,
is such a...
I put in they were all silicone.
Yeah.
Have to wrap this up.
We didn't have CDR measurements back then either, so.
Yeah, we didn't.
All right, we're running out of time. Oh, yes, Michelle, quickly. One last question.
I'm a pharmacist, and listening to this, has anybody systematically looked at what, as a, you're looking at pH, you're looking at various things. Has anybody systematically looked at the formulations that they're in? Because I'm looking at some of these things and I'm seeing patterns here, patterns based on stuff I already know. And I don't know if anybody's formally looked at your list of drugs and actually looked at what they're dissolved in, because I'm recognizing certain lipids here.
You're talking about
there's studies, especially in Europe, that we've drawn on. Manrique Rodriguez is a good one.
Right.
There's several now that are looking at diluents and concentrations. Right. Yes.
But it's your main question about the co-solvents and excipients in the drug formulation itself.
Well, I'm seeing like some of your problem drugs that you've raised, what I know that they're dissolved in as a pharmacist, I'm seeing patterns there that are probably as strong as the drugs. And so I wonder if has anybody formally looked at that?
Our work on the vesicants and in the table that we will be publishing did look at that from an osmolarity standpoint, where we could find that data on a particular drug if there was a specific osmolarity that was reported. That I can't remember the details. Lisa, you're familiar.
Yeah, I actually in the chat, I actually copied out and pasted in just an example of some of the data that we're providing. That was in the chat. It's up a bunch. It was acetazolamide, and where we, put forth lists the pH, IV push versus an infusion, the diluents, those 12s. The 12 after that, those are like the citation number. They shouldn't be that big, but so we're trying to provide as much possible information there. When there's an asterisk in the chat, you see that was the pharmacist actual calculation, because we do have a pharmacist, Jenny Ong, on our team looking at that very type of data. Does that make sense?
Yeah, that makes sense. It sort of answered my question, so that's good.
Yeah, there's a guy by the name of Mark Strands who
Oh,
Yeah,
we've-
yeah, he's
he
done
was
a
on
bit of
the-
work. He's done a bit of work in
Yeah.
that area. He's a pharmacist and done a bit of work again around like what drugs are compounded with, and its effect on the glycocalyx and whatnot.
Mhm.
Okay. I'm gonna
Yeah, he was
close
on
it
our
there. We've got
2017
another
committee.
meeting.
And he's kind of been a consultant to us along. So I mean, we
Yeah.
do ask him questions along the way. Barb presents with him routinely. So
All right. I'm going to close it there. Thanks so much, everybody. Thanks, Lynn and Barb and Lisa. Absolute pleasure to have you come along and chat to us. We have another meeting, so everyone now has to dial out of Zoom and go onto their Teams link if they're coming to the next meeting. So thanks again. Fantastic. We'll look forward to getting the PDF of your slides, and we'll share that.
Okay, sounds
Thanks for
good.
inviting us.
Thanks.
Bye.
See you at
Yeah.
the next meeting.
Bye. Thank you so much, everyone. Really interesting.
Thank you. Bye-bye.
Bye.
Bye.
bye. Bye.